This conference will now be recorded.
Hello, everybody. This is Len Sierra with AnCan, Advanced High Risk Recurrent Prostate Cancer Video Chat, June 15th, 2021. And we're going to start with a new member, George Rovder. George, hopefully Jim filled you in on the questionnaire we use for new people to help move it along quickly.
He did.
So I'm going to ask you a few questions, and if you could just answer them as we go through. So how old are you, George?
I'm 70.
Okay, you look good. And where do you live?
Arlington, Virginia.
Very nice. How did you hear about AnCan? I guess through Jim Marshall.
My friend Jim Marshall.
Very good. And when were you first diagnosed?
It was last month. Days go by so quickly, but it's, I'd say, less than a month ago.
Okay. And from what I've heard from Jim, I think you had a Gleason 8.
That's right.
And your PSA level was what?
17.
Okay. And I'm guessing you haven't had a follow-up PSA since then, since it was just last month. Is that right?
That's correct. I had 2 that confirmed that it was 17.
Okay. So which doctors are you seeing and at which institution?
It's at Virginia Hospital Center in Arlington, and it's Dr. Yoel. He's in the urology department at Virginia Hospital Center. Yoel is spelled Joel, Joel.
Okay. He's a urologist.
Correct.
And you haven't seen anyone else yet?
I haven't seen. I have an appointment tomorrow with oncology. Oncology radiation.
Radiation oncologist. Okay.
Mm-hmm.
And how did that get set up? Was that through Dr. Yoel?
He sent me to that department. Yes, that was his recommendation. So Dr. Yoel said that my Gleason 8 is very high risk based on the number of cores that had the positive cores. And he said that he could operate on me, but I would require, he would have positive margins after the surgery, and that would require radiation, and radiation starting at my baseline after radical prostatectomy. My urinary control would be 0. And once the radiation starts, you could get back your control, but only to where it was when radiation started. And that means I would be incontinent forever. So he didn't want to operate on me.
Okay, and then how does he know that your cancer is beyond the prostate? Did he do any scans?
I had an MRI, yes. So it started with the PSA. He sent me first for a scan, and that showed that there was seminal vesicle invasion. And after the scan, he ordered the biopsy.
Okay. Any positive lymph nodes in the pelvic region?
He didn't do a lymph node biopsy.
No, not a biopsy, but
dissection. So the MRI did not show.
Pick up anything else?
The MRI did not indicate that there was any swelling of the lymph nodes.
Okay, and no bone lesions, suspicious bone lesions?
I did have a bone scan yesterday, and that came out negative.
Okay.
What type of bone scan did you have?
I had a standard bone scan, so it wasn't a PSMA PET scan. It was, I don't know. I mean, I could look it up if it's important for this discussion. I could see if, you know.
Well, you can just tell us, how did they do it? Did they inject you with a solution to make you wait a few hours?
That's what they did.
Yeah, it sounds like technetium bone scan.
Right.
Okay.
Excuse me. Okay. So do you have any specific questions for our group?
I do. So with surgery off the table, Dr. Yole indicated that I would have radiation, and he said it would be traditional radiation because of the extent, and possible secondary radiation, whatever that would be. And he said that should start with the ADT. So I've been in touch with Dr. Yule since, thanks to Jim Marshall, about this PET scan, the PSMA PET scan, and I'm trying to find one because if the cancer is distantly metastasized, then all this radiation to the abdomen won't do any good. So I don't want to go through that without knowing really for sure that there is a distant metastasis. So if anybody knows, my question is two questions. One, if I start ADT, is that okay? I could still get an accurate PET scan, PSMA PET scan while on ADT? Question one. And question two, where could I get a PSMA PET scan?
Before we answer that, I forgot to ask you, did they do a CT scan of the chest, abdomen, pelvis?
They did not.
Okay.
No?
I think they probably should.
Yeah,
You guys
that's
agree?
protocol.
Yeah.
There's
Yeah.
a few things that give me some concern here, George. But CT and bone scan are absolute protocol. They're required. So it would make me question Arlington Hospital.
Okay. Yeah. Well, Dr. Yule knows that I'm going, it didn't end with him. So I'll go to the care of the oncology radiology, and then I'm sure that they would make sure that's done. If they
Not necessarily.
Okay.
I mean, we can talk about a few things here, but there's a couple of things. It isn't necessarily redundant to get the radiation even if the cancer is systemic.
Okay.
In the old 5 or 10 years ago, that was the case. Certainly 10 years ago, if the cancer was systemic, they would not treat the prostate. But today it's very different, and there are a number of these guys, a number of guys on this call who were diagnosed de novo metastatic, meaning they were metastatic at the first diagnosis, who have had their prostate treated. Herb, Ken, and I'm sure there's a couple of other people here where subsequently, Jerry Pelfrey, where subsequently the doctors have gone in and they've treated. Now, I'm also concerned about the fact that your guy is talking about regular radiation being the only option and the standard of care for you, because that isn't the case, and there are plenty of papers that would say that the gold standard treatment for you would probably be brachytherapy or possibly SBRT, stereotactic radiation, plus radiation to the pelvic girdle, plus hormone therapy. And we can provide those papers. We can direct you where to find those papers, but they are. It's really clear that that is probably the best option for a man who's diagnosed 4+4 or higher with the type of complications that you have. How many of your cores were positive?
I don't know the exact number, but there was enough to make it a high risk categorization of the
Well,
cancer.
4+4 makes you high risk. 17 actually doesn't make you high risk.
I'm sorry, very high risk, not high risk, very high risk.
Yeah, well, I wouldn't even say you were very high risk. I mean, very high risk is usually 4+5 or higher.
Okay.
And 17 in and of itself doesn't warrant high risk. If you're 4+3, then it has to be over 20 to make you high risk. So there's a lot of information that you're getting that really doesn't necessarily agree with the standards of the protocol standards. Do you have a copy of your biopsy report?
I do. I don't have it at hand. I'm sorry.
That's okay. But as long as you've got a copy, because we can talk about it. But I mean, it sounds to me just with the SVI and the fact they could identify extracapillary extension, that it doesn't really matter that much in terms of the number of cores, because we know that you've got to throw the works at it, and the best works you can throw at it are either brachytherapy, depending on the amount of volume, high dose or low dose brachytherapy, and or SBRT, because there's now some evidence that the cyberknife focal type of radiation could be as good as the brachytherapy. So that's kind of debatable, but one or the other for sure. Plus at least 18 months of hormone therapy, plus radiation to the full pelvic girdle. And anything less than, if it were me, I wouldn't contemplate anything less than that combination. I was pretty lucky because I had locally advanced, not quite as bad as yours, but I did have locally advanced. So I was probably stage 3, which sounds like you are, without doing a PSMA, we don't know. And it worked for me. So there's hope that it can work for you.
Yeah.
So, you know, one of the things I would probably be doing is going to a different institution and getting some second opinions on this treatment. One other thing that'll be helpful for you to hear is that I got diagnosed in May. I had a high PSA in May. I did my biopsy, got my biopsy results by August, and the doc said I had to start treatment by the beginning of the next year. So that was sort of the time frame. So
what year?
Do something, but you've got time. You've got plenty of time to get some more opinions. And I think that we've got so many people now on this call from the Virginia. Hold on a second, DMV. Thank you. From the DMV, that we can probably direct you to a couple of good alternatives.
What year were you diagnosed, Jim? Rick, I'm sorry.
Oh, I was diagnosed in 2007.
Okay. So this is all new to me. So what I said is what I understand is coming, but I've not spoken with the radiation people yet. So this was the urologist saying, you're not going to have surgery, go to talk to the radiation people, which I will do tomorrow. So the things that I've thrown out there is just my understanding of what might transpire, number one. Okay. Number two, I do have an appointment with another institution, so I'm not going to do the first thing that comes along.
So George,
yes.
I think one of the things this group will tell you is that for every specialty you see, you need somebody who really is a specialist in prostate cancer.
Right.
Taking care of you. from the radiation oncologist to your urologist to some, and even if you need a medical oncologist. But the disease is such, the nuances are such that having people who deal with prostate and prostate only, I think would be important for you.
That's very good advice, Herb, and that's what I'm looking at. When I go to an institution to see what they have, I go to the prostate radiologist, yeah.
Right. So, for example, the guy I used at Georgetown, I think is really good, and he came to me highly recommended.
I'm going to see Dr. Sean Collins at Georgetown.
That's who I used. I think
he's a good guy.
The right guy.
Okay, good.
I think, George, you can probably say goodbye to your urologist. And in addition to talking to the radiation oncologist, you should also speak to a GU medical oncologist. And those will be your two providers for at least the foreseeable future. But you have no need for a urologist, in my opinion. I don't know about the other fellows.
No, I would agree. Once he said he's not going to do surgery, you don't need him anymore.
Right. Yeah, I wouldn't be putting, any further care in his hands. Like the hormone therapy is best handled by the medical oncologist. And you had asked the question, should you start hormone therapy before the radiation? And I guess the question is, how soon will they be able to start radiating you? Because on the one hand, you don't want the PSA to get too high. On the other hand, if you go on hormone therapy, it might drop your PSA down very low very quickly, which may make it difficult for an Axumin scan or a PSMA PET scan to pick anything up. What do you guys think about,
I think the PSMA PET scan would be, and I think Georgia should be able to get it. According to what I read from the company website, they said it would be widely available on the East Coast as of now.
Yeah, I went to the website that's Pylarify, and they said it's available in Sterling, Virginia. And I told Arlington Hospital Center that I would go to Sterling and get it for them. So yeah, it's Sterling. I mean, that's our neighborhood, and their website says it's available. So yeah. But
I think that would be something you should do soon.
Yes, that's what I hope to do. I've been trying, and I do understand that Inova Hospital started that today. Started the PSMA PET scan today, but I'll call them back tomorrow to verify that.
And does anyone know
I want to throw out another alternative to you, because with a PSA of 17, I think you could reasonably get an Axumin scan. If you have any issues getting the Pylarify approved just yet, because it's supposed to be available, but we don't know how the insurances are going to respond to it, and I don't think Medicare has officially said, although I think it has to approve it because it's for FDA approved, so it has to approve it, but it hasn't said officially. But with a PSA of 17, you're going to get a pretty good result from an Axumin scan as well, which is the 18F fluo. I can never say it. Ben will say it for me.
Flucyclovine.
Flucyclovine, right? The benefit of the better, newer scan is for people like Joe Gallo, where we're trying to see exactly where it is in the prostate and how much there is, or for people with recurrence who have a very low PSA. But for somebody like you, it's a good option, but it's somewhat overkill. And it's
Rick, I've had a TERP. So once you've had a TERP, is the PSA accurate, or does that need to be jacked up to be?
How long ago did you have the TERP?
The TERP was in 2017.
No, I mean, I've never heard that a TERP distorts the PSA.
I've heard that you have to double the value that the serum test takes,
I've
and that
never
gives you
heard
your equivalent. Okay.
I've heard it that's certainly true if you're on certain drugs like dutasteride or finasteride.
Okay.
But has anyone else heard that a TERP distorts the PSA? I've never heard.
Possibly
This is
short
seriously
term, but certainly not 4 years later.
right. In the short term, you'll get inflammation. So if you got one right after, yes, but not in the long run.
Okay. Thank you.
So, you know, I do think it's a good idea to get better scanning, but I think an Axumin scan. I mean, guys, what do you? What
I
about
agree
our
with you,
brain
Rick.
trust here? What do you think?
I agree.
So, you know, don't make yourself crazy trying to get Pylarify when it's only been available for about a week.
Spell that for me, Rick.
Which Pylarify or the other one?
The other one, Axumin.
Axumin, AXUM as in Mary, IN as in
Okay.
Nelson.
All righty.
And that's been available sometime. You know, once your PSA is above around 0.85 to 1, it's close to being as good as the Gallium and the 17F DCF PYL. I think, guys, didn't somebody do a trial or a test and compare them when your PSA was a little higher? Does anybody know about that?
I think Alan Adele did one a year or so ago. Is that what you're thinking of, Rick?
No, I'm thinking of something more recently where there were actually some tests, and they and they said that once you got over about 2 or 3, maybe it was from one of the gurus on one of the webinars. They said once you get over about 2.0 or 3.0, there's really not much that much difference between the PSMA scans and the Axumin scan.
Yeah, I agree with that. So Rick, I know you said we have to have a sharp cutoff at 8 today, so I'd like to move on. Thanks for joining us, George, and please come back and let us know how you're progressing.
Thank you for giving me so much time and so much advice. And if I wanted to get in touch with somebody, was it Herb that said you've been treated at Georgetown MedStar?
Yes, I have.
By Dr. Collins?
Right. You can write me at herb@ancan.org.
Okay. Thank you.
And I'm happy to talk about anything. I think we're fortunate that we live in an area with a lot of good people.
Yes, I agree. Thank you, Herb.
And just a quick word, I think everybody knows, but just in case, the chat window is the bubble in the top right, and we're putting these email addresses and a lot of other information in the chat window.
Okay, thanks.
All right, so John Birch, I think by now you have an idea of how the new member inquiry goes. Are you ready?
Let's go. Yep.
Let's go. Let's do it. How old are you, John?
67.
All right. And where do you live?
Dallas.
Okay. And how did you hear about AnCan?
A good friend of mine, Denny McGuire, is a participant.
Oh, how do you know Dennis McGuire?
Yes.
How did you become an acquaintance of his? He's up in Michigan, or Wisconsin.
Milwaukee. Danny and I lived in the same town in Connecticut for a number of years and knew each other socially and played golf together.
Ah.
We were just outside of New York. We were just outside New York City at the time in Ridgefield, Connecticut.
Ridgefield. Yeah, okay. I'm in Danbury.
Oh, okay.
All right. And so, John, when were you first diagnosed?
2006.
All right. And what was your PSA and your Gleason level?
The Gleason originally was read as an 8. Later on, when I landed at Sloan Kettering, they bumped that to a 9. Excuse me. I don't recall what the Gleason or what the PSA was at the time of initial time of diagnosis.
All right. The Gleason was 4 plus 5?
That's what it was written, revised to. I think it was a 4 plus 4.
Okay. And who did you see at MSK?
Well, I had the prostatectomy was done at Henry Ford in Detroit. I was living in Cincinnati at the time, and they were the closest hospital with the Da Vinci. So I had the prostatectomy done in August of 2006, and then moved to the East Coast into Connecticut in early 2007, and had the radiation done because the margins had been breached when they pulled the prostatectomy. Had radiation done in the spring of 2007 at Sloan Kettering, Dr. Yamada. And then I was seeing Dr. Slovan for intervening time from the post-radiation until we moved down to Texas in 2019.
Okay, so between the time you had the salvage radiation and 2019, when you moved to Dallas, what was going on in those years?
A lot of everything. Was on a number of different drugs and therapies. Did the Dr. Slovan had me on, pulled me off of the Lupron, and we went on and off, kind of cycled through the Lupron treatment. I did Nalandrin, flutamide, Zytiga, Xtandi, and about 3 years ago I did 6 rounds of Zofogio, which is the radium 233.
Right. When was that?
That would have been early 2018.
So you had bone mets at that time, but no visceral or lymph node involvement. Is that right?
Yeah, I still don't have any soft tissue. Everything that I have is in the bone.
Okay. So that was that your last interventions of Vigo?
No, I've done docetaxel from March 2019 until just recently. I did 27 rounds of docetaxel.
How many rounds?
27.
27. Hey,
Uh-oh.
hey,
Oh,
Ken.
Ken, watch out, Ken. Ken, you got competition, man. Careful.
It's
Okay.
a number.
It's
It's
all
a
right.
number.
Ken.
It's all I look at it. It's a number.
That's right. Well, wait a minute. Ken's at 19, but we shouldn't forget the original 6. So he's at 25. Oh, maybe you've got the competition, Mr. Birch.
Well,
he's creeping up on you.
well, we've done a number of rounds, and the effect has been it's knocked the PSA down. In the last I don't know, the last 3 or 4 rounds, it's been steady. It has not stopped working. It's not that it's not stopped working. It's how much can your body take. And I've basically got to the end. I realized how worn down I was from all those the rounds of chemo. And we're in a little bit of a break. I've been off. It's been 7 weeks since I had a chemo round, and the next move I think is going to be to a PARP inhibitor, to olaparib.
So, John, it sounded like you said your PSA is stabilized, not going up, not going down.
Yeah, but it's the docetaxel is keeping it in check, and it's
That
pretty.
level.
It's a pretty good number too. I mean, in terms of
What
the PSA.
What's the PSA level?
It's in the 900 range.
900. Okay, and they're using olaparib because you have was that following a genome sequencing where you were BRCA2 positive or ATM or anything?
ATM. So that's what the I'm seeing Dr. Courtney now at University of Texas Southwestern, and the thinking is we'll go to the PARP inhibitor now and give that a go after all the chemo.
How is your bone marrow? What's your platelet levels, white blood cells?
The whites are in the 3 to 4 to 5 range. It's a little bit hard to tell because I've been every chemo round I'd get the Neulasta. The platelets are running about 160. The reds, the reds are just over 10. They had started to dip a little bit into the 9s, but the hemoglobin is back up over 10 now.
Okay, so it sounds like you're in good enough shape to take on olaparib. And when is that starting?
Well, the decision is in a couple of weeks. My next checkup, my next appointment.
So John, I was on a webinar this morning. It was really a continuing ed designed for oncologists and what have you, and I was sort of listening with Wasim Abida from Memorial Sloan Kettering and Chuck Ryan, and then another guy I'd never heard before, and it was on PARP inhibitors. And it's fairly well recognized that the response to ATM is very low. It was approved for ATM, but frankly, that was because the trial design was poor. And ATM kind of snuck in there. But what we know is that the BRCA, that if you're BRCA1 or BRCA2, you're going to get a result. If you're ADM, around 10% of the guys, 12% of the guys respond. It's very low. And I know that it's approved, but I would be challenging Dr. Courtney to look at the data and listen to the webinars, because there's plenty of evidence that it's not a very good option for ATM. And you know, there are a couple of other things that I might consider. If it were me, I would be considering to try and get into. For example, certainly a lutetium trial, like Dennis just did, and he's gotten good results out of that. Another thought is possibly a carboplatin. Another thought is trying to get into a BITE trial right now. Bispecific they're called BITEs, capital B, small I, capital T, capital E. It stands for bispecific T-cell engager. And essentially what it is a molecule that grabs a T-cell with one arm, and then the other arm is attracted to the cancer, usually through PSMA. But there are different types of BITE molecules. So, but in your situation, there just isn't the evidence that it works for ATM.
Well, Courtney's quoting about a 50% rate for the ATM. It's not a slam dunk by any means. He's never said it, but he's got a 50% works on ATM, and it is, and he says it is higher on the BRCA1 and 2.
Well, I'd like to see where he gets that 50% from, because I've never seen that. And I mean, in this continuing ed trial this morning, continuing ed webinar this morning, they pointed out the numbers again, and the numbers are in the low teens. Len, do you? I mean, we looked at this carefully. Do you remember the ATM response?
Well,
Definitely lower than 50%.
right. I mean,
Lower
there
than
was
50%.
there was just another presentation at ASCO about this, and it was well considered. They were definitely saying that yes, use it for BRCA1 and 2, but others are not so sure.
Yeah, I mean,
In Europe, it hasn't. It's only approved for BRCA1 and 2, not for ATM.
yeah, I mean,
Also,
you ask
the other,
Courtney. If Courtney's got evidence, that's fine. But I don't think the evidence there. And I think if he's telling you it's 50%, he's feeding you a bit of a line, John. I don't think it's even close.
Okay.
And there are numbers out there. There is evidence out there. I mean, we could research it for you, but the numbers are there. If they happen to send me the slides, sometimes they'll send the link to the slides. And if they happen to send the slides, I'll go to the slide and I'll try and copy it for you and send it to you. But the slides on the ATM were really clear with olaparib. I mean, they were comparing olaparib, rucaparib, talazoparib, and they had the mutations down the side. But the numbers are not hard to find. Just Google ATM response to PARP inhibitors, and you'll find it. You know, one of the things we try to do on these calls is to guide you, to make you your best advocate. If you can go do the research yourself and find it, you're going to be much more comfortable talking to Courtney about it. But he may have something up his sleeve that none of us know about, including Chuck Ryan and Abida.
Right. No, I've done the research, and I realized that the ATM was not up in the ranks of the BRCA, but at the same time, I haven't seen anything that's as negative as what you're talking about, or as low as what you've described.
I think maybe Carl Foreman remembers, but I think even with the BRCA, the numbers were only in the 60s and 70s response to the PARP. I mean, I don't know. Anybody remember those numbers? But I don't think that.
I think it was even lower than that, Rick.
Was it?
Even for BRCA.
Yeah.
But I remember from the Profound trial, I think it was the Profound trial, what they were considering response from ATM was that they weren't seeing PSA declines. They were, or radiographic progression-free survival. All the biomarker that they were using was that it decreased the number of CTCs, circulating tumor cells, in your blood. So, I mean, even the biomarker itself was kind of a weak surrogate for a legitimate response, in my opinion. But yeah, as Rick said, talk to Courtney and let him show you the data.
I can go back to Slovan too at Sloan Kettering. I've still got a relationship there.
Yeah, that would be a good person. I'm curious, how did you like Slovan?
I loved her.
Great. Okay.
There's differences of opinions about her, but she was terrific for me.
Okay, and that's good to hear, because we get mixed reports about that she can be a bit of a cold fish, but then sometimes she just seems to open up and she's great. So,
well, you gotta work her a little bit, but
okay.
I was with her for over 10 years, so
yeah. I mean, I would go back to her. I think that's a great idea, John. Go back to her and specifically ask her what she knows to be the response from PARP inhibitors for men with an ATM mutation. Be very specific, because she'll know where to find that data right off the top. I mean, I could find it, Herb could find it, Len, but it's going to take us a little bit of work. She'll know where to look for it right off the top.
Yeah, she probably knows it off the top of her head. So,
Yeah.
okay.
Yeah.
I've already found a couple of papers which exactly say what we've been saying, and I'm going to try to put them in the chat, the links in the chat window. But the universal opinion, and there's actually been a recent review of April 2021 on this subject by Antonarakis, and the conclusion is that other DNA alterations, and this means ATM, might also sensitize to PARP inhibitors, though the response rates are lower, so other standard therapy should be prioritized. So, I mean, I guess since you've had the other standard therapies, it may be time to do this, and it may work for you. That's another way to look at it.
Right. Well, there aren't a lot of options at this point, so, you know, and the docetaxel was wearing me out, so I'm up for trying something
Right.
else.
You know, I mean, it's probably not a good time right now, but with that ATM mutation, you may be a good candidate when you feel better for a platinum, or to combine a platinum with, say, Jeftana. That's something I would be asking cabazitaxel. That's something I'd be asking Courtney about. But I'd also be doing a bunch of research into the trials that are out there, and I'd be looking at the BITE trials, and I'd be looking at the lutetium trials. There are 3 or 4 lutetium trials. There is one you might be eligible for with ketoconazole. I'm trying to remember where that is. Where you're eligible if you have not done chemo within the last 4 weeks, because there's a couple of them where you couldn't have done chemo within the last year, which obviously isn't going to work for you. But there's a couple of them where you haven't done it within the last 4 weeks. But I would definitely be looking at either a BITE trial or a radionuclide trial. I mean, Len and Herb and Peter, what do you think?
I agree with that.
I agree.
Yeah, this is Ken Anderson. I would agree too.
Yeah, I'm sorry, Ken. I should have included you.
What were the last 2? A radio what?
Radionuclide.
177.
Is that the lutetium?
Yeah, that's the
Yes.
radioligand he was talking about.
No, I thought
But
I thought those trials were closed and they were moving to with the FDA approval, or moving to FDA approval.
They
some of them are
probably
still open. Some of them are still open. You need to go to, if you go to clinicaltrials.gov, you can look at the list. I think there's about 13 on there, and you'll see which ones are still open and which ones are closed, which ones are open and recruiting.
Okay.
And I know because I just went through it for Jerry Deans, and there are still a couple that are recruiting. So, you know, that's a similar treatment to what Dennis did, but we're not only talking about lutetium. I mean, for example, there's Carl, there's an Actium trial that's open at Weill Cornell right now, isn't that right?
Right.
Carl?
Nope, I had to get off of mute. Yes, that's right.
What do you know about that one for John?
Well, I guess we would have to, I don't know any of the details other than Dr. Tagawa's office to be able to help him with that.
Okay.
John, this is Peter Kafka. On a different note, I'm very impressed with you. I mean, for dealing with a very serious disease for 16 years and advocating for yourself and going to all the right centers of excellence and the right docs and and being on top of all the treatments you've had, you're a pretty impressive guy. And I think we all wish you well. I mean, this is a tough situation you're in, but you're a remarkable guy. Remarkable. I mean, I hope, you know, when I get 16 years into my disease, I'm as clear-headed as you are about the whole path I've taken. So,
Well,
Yeah,
I agree with Peter. I agree, Peter. John, you're actually an inspiration for most of us.
yeah, we've got a bunch of Gleason 9s. Probably none of us think we could last 16 years, so that's really good news for all of us.
Well,
No, Lynn. I'm following that guy.
well, I appreciate the comments, but you know, it's all about really at this point just trying to find something to kick the can down the street far enough and
So
keep going.
You
and
did writing in
live
223.
live the rest of your life and
How
use
does
that
that
as a
work?
distraction to the disease.
Herb, were you trying to say something?
No, I mean, there are a couple of trials now combining Xofigo with PARP inhibitors. Now, I know you've had that already, and they may not want to give it to you again. But the whole idea is that you know, the PARP inhibitor by itself does a certain job, but if you combine it with something that's sort of doing more DNA damage, like radiation, that may enable ATM deficiency to kick in and make a difference. But I don't,
Yeah,
again, it's a trial.
they were discussing all these combinations in this webinar this morning, Herb. They're combining it with abiraterone, they're combining it with enzalutamide, they're combining it with a PARP inhibitor. It really wasn't clear to me about the impact of PARP inhibitors with lutetium. And they seem to say that they think there may be some interaction. But you know, I think the issue with air is that they're delivering them in combination.
Mm-hmm.
So you know, maybe the PARP inhibitor delivered in combination with something might have some benefit, but the PARP inhibitor delivered on its own for ATM, I think is sketchy.
Yeah, I mean, I agree. And I mean, John, the other way to look at it is if you're interested, if they think a PARP inhibitor might work for you, there may be some trials where they're combining it. And those trials might be more advantageous than using it alone.
Right. Okay, that's good thought. Well, let me do some more research.
Yeah, please come back, John.
Come back, and I'd like to hear the results of your research.
Okay.
All right, there's a couple of guys who have arrived. I just want to check in with them, see if they would like any time tonight. Peter, how about you? Peter Kafka?
No, I think I'm pretty good. I just got my first shipment of Orgovix today, but I don't start taking it for a couple of weeks.
Oh, great. Okay. I think you're our third Orgovix member. Is that right, Rick?
Fourth, I think.
Fourth. We got John Ivory and
Frank Fabish.
Frank David.
I pronounced it correctly. It's Orgovix.
Orgovix. Okay.
And it's
who? I forget who.
All right. Mr. Brooklyn himself, Larry Fish, would you like time tonight?
Hey, Len. Good to see you, everybody, but not tonight. Thank you.
All right. Let's see. AnCan, would you like any time tonight?
Yes, if at the end, maybe 2 minutes, if there's time at the end.
Okay. All right. Let's go to Jake. You said you had something for us.
Yeah, thanks. I got my cancer seems to be marching steadily along. I keep telling it to cut that shit out, but it doesn't listen to me. So it's doing its own thing. I've been on an oral chemotherapy for 50 days, give or take a day or so. And so far it does not seem to be working. My PSA went from 373 in April to 506 just the other day. And my alkaline phosphatase is through the roof. It's up to 241. So it's like doubled in the last month. So there's definitely something going on with my bones for sure. I sent a note to Antonarakis, who suggested the oral chemotherapy in the first place. And he said, well, 373 to 576 or 373 to 506 is a 35% rate of increase. And he said he wouldn't be too concerned. He said he suggested I give it another 45 days, which is pretty much what I was thinking of doing anyway, at least giving it another 30 days. So that's
how are you tolerating it, Jake?
Yeah, it doesn't seem to bother me, Len. I mean, I've been tired since I've been on Lupron since 2012. I've been tired all along, so it doesn't bother me any more than that does. It's part of the program.
Yeah. Anybody have questions for Jake?
All I can say, Jake, try that marijuana a little more.
Yeah, I was telling Ken, I've smoked cigarettes. I've been smoking since I was like 7 years old, and I took a puff off this vaping pen, and it made me cough like a madman. You think that after 60 years of smoking cigarettes, a vaping pen wouldn't have any effect on me, but it did. So I am going to try it again, Ken.
Hey, the pharmacokinetics are much better if you eat it.
You eat it?
And you don't have to worry. Eat it. Yes. They have edibles, Jay.
Herb, I didn't send him gummy bears. I sent him vaping pen.
Okay.
Yeah, he
Herbs aside. Hey, herbs aside. Hi, Jake.
Hi, Len.
What I always think about often when people are talking, and myself included, is go to these great doctors and you're working on something like you're taking this chemo pills, and in 50 days you don't see any improvement, to say the least. And the plan is to stick with it 45. But do people discuss, like, so what's the next plan? Or most docs, well, we're sticking with this plan and then we'll think about a next plan. And I'm always thinking that you should have a couple of next plans in your mind. I thought about this with her, myself, other people, like, okay, we're working on things. They're not exactly working. Just don't want to hang out there. Doctors tend to like to do that. I want to push the docs a little bit for, well, what do you think if this is not working? You have a couple of options in mind, just to get the thinking going, so you have something to research. I don't know. I've had this thought a lot.
Good point. It's a good point. I did that exactly with my doc last week, and I asked about Keytruda, and he said, "Oh yeah, we should do this swab and check to see if you can take Keytruda." And the nurse comes in with this mouth swab and sends it away to a lab. I mean, you're right. You got to ask about next steps.
It's just a thought that's been running through me for a long time. Keep on having, try to stay a step ahead, and just to have a plan, whatever the difficulty is. Like, not to just sit there in limbo. I don't know. I always like to have, well, I'm going to look forward to the pleasure of this next step.
I think it's a good idea too.
Yeah, and Antonarakis did say that he thinks, in my case, the next best thing would be probably radium-223, unless lutetium gets approved. Not the scanning part of it, but the treatment part of it. Unless that gets approved, then probably radium-223 will be the next thing on my list of things to do.
Hey, Jake, I see that you've got some cladding on top of your head again. This Wow. So this chemo is allowing your hair to grow in, huh?
Yeah, it didn't affect it at all, believe it or not.
Wow. Look at that. You better change your picture again. We don't know who that bald guy is. That's great.
Yeah.
Even his beard is coming in better.
Yeah,
Oh,
I
nice.
actually shaved it off, Len, because it was looking kind of scraggly. But yeah, you're right. I could actually grow a beard a little bit. So there are
All right.
benefits.
All right, Jake, we wish you well.
Thank you.
Let's go to Peter Monaco.
Len, can I make an addition?
Go ahead.
Jake, it's an expensive way to do it, but I just heard today that somebody is, they were advised by their doctor at Sloan Kettering that if they wanted to try the lutetium for treatment purposes, they are doing it in Germany. And the doctor at Sloan told this guy who could afford it, he said, you should go to Germany for these treatments.
Well, we've known people that have done that. We've known people go to Australia, and we've known people go to Germany. Probably the last one was Dr. Rex, who we lost in this maybe about 4 or 5 months ago, and he went to Germany. But what's really happened in the last 6 months here is that there's been more trial availability in this country. And if you work at trying to find the trials, and Dennis McGuire is a really good example of that. If you work to find the trials, there's a good chance that you still can get in over here. But to do it overseas, I think it's probably about 40 to 50 grand, if I remember correctly.
But it's all moot because we all know going to Germany for Jake is like going to Mars, so that's not happening.
That's right.
Yeah, not to mention the 40 grand.
Yeah, right.
But
Minor-
thanks for the thought, Gary. Thank you for the thought.
Yeah.
All right, let's get back to Peter Monaco.
Hi. So under the direction of my new oncologist, Dr. Patel with Mount Sinai, I'm switching off from the combo of Lupron and Casedex to Lupron and Zytiga, effective immediately. As you know, I was communicating with you. He initially had prescribed Xtandi, but I couldn't get the patient discount deal that they offer to some people. And it was like, that's like $2,100 a month. So anyway, I know you guys thought that Zytiga was a better choice to start. And I contacted him and he had no problem changing me to Zytiga and prednisone. And I'll be starting that in a couple of days when the shipment comes in. So that's my new direction.
Ooh.
Peter, that number I gave you, that was no good. They wouldn't support you for the Xtandi?
No, I went on that. I clicked on that link and went to that site and filled in their questionnaire, and they said no can do. So
did they say why?
So Peter?
No, they just turn you down, like you don't qualify. So I don't know what it was. You know.
Interesting.
Could be based on income.
No, it wasn't that detailed. They asked, did I have, like, do you have government type insurance? And my prescription drug insurance is with WellCare. I don't think that's not Medicare or anything like that. So I don't know. I put in the numbers, the membership numbers and all those ID numbers that are on my card. This is the insurance I have, and it came back, you don't qualify. So I really had to change to Zytiga after that, because that was.
So Peter,
yes.
How much are you paying for Zytiga?
It's going to be about $55 a month, so pretty affordable.
Oh, that's a good price, yeah.
Yeah. Well, I think it's the generic, but whatever. It's that's much more doable than $2,100 a month. So I made the switch. I had a question, if anyone knows. I mean, I should run this by Dr. Patel, but should I start the Zytiga like literally, the next day and, drop the Casedex and proceed with, or do I have to have any gap time in between? Does anyone know that?
I
see
don't
why
think
you
you should need any.
gap time.
No, I think you should just take the Zytiga.
Okay, so if I take the Casedex on Thursday and the shipment comes in later on Thursday, starting Friday morning, I can start taking the Zytiga.
Yeah,
Right,
listen,
exactly.
I think you should check with Patel. We don't think so.
Mm-hmm.
But, Peter, we can't give you that sort of medical
Right.
advice. But,
Yeah.
but that said, the guys don't seem to think so. I don't think we've ever been asked that question before. Usually there's sort of a lag, but it probably shouldn't make that much difference. I mean, we just were talking, Len and I were discussing online about a trial where they switched you from enzalutamide to darolutamide after whatever it was it 90 days, Len? And then 90 days, and they switched you straight across. So they didn't gap you in between.
Right.
So, I mean, one would think not, but just confirm it, send a note and ask them. And the other thing I want to say is that, all of the evidence seems to indicate that you're much better off sequencing abiraterone before it's enzalutamide and not after. So I think most of us on this call, if we were going to do something, we do abiraterone first and then we do enzalutamide after anyway. So you're in.
Yeah,
and I had a question. Go ahead, Len. Go ahead. I'm sorry.
I was just going to say, Casedex is a receptor antagonist, and there at ASCO they reported results of a trial where they used Zytiga and another receptor antagonist, apalutamide, together. So I can't imagine why there would be any need to, gap Casedex and Zytiga. But like Rick says, talk to Patel.
I was going to say, I went to see Patel on Friday, and that's when I made my official decision after going over everything with him. And, he had me do, before I left, he had me do he did some blood work to establish a baseline. And I can say that the Lupron and Casedex looks like it's working. I was on Lupron for 16 days and the Casedex maybe 26 days at the point of getting this blood drawn on Friday. And my PSA dropped from 1.83 to 0.29. And the testosterone, it was still around 130, I think, 135. So I thought that was a pretty good response so far after only 16 days on the Lupron.
Yeah, and I think it's what we all expected. I certainly expected it because weren't you just you were a 4+3, right?
No, 4+4.
Oh, 4+4? Okay. Well, anyway, good to see that you're responding very well and quickly.
So Peter, have we convinced you that you're going to be around for longer than 6 months?
Well, I appreciate you guys really talked me off the ledge last week. So I do appreciate that, and I'm feeling more optimistic. Learning to live with the news. I did have a question about side effects. Like Zytiga, and that's taken with this prednisone stuff. You got to take that with that. Am I going to be wiped out with this?
How much prednisone are they giving you?
I don't know the dose, Herb, exactly. I don't even have the pills yet.
The answer is, it depends, but chances are not.
All I want to know is, am I going to be able to play golf anymore?
You're going to play golf.
Hold on.
Right.
Hold on.
It's like,
we need Dennis Correa.
Can I play the piano?
Guys,
right.
hold on, Herb. We need Dennis Correa because this is where we get the testimony for the prednisone, right, Dennis?
That's right, Rick. I did it, Peter, same thing, Lupron plus the Zytiga with the prednisone. And my golf game actually went up a notch because I think the prednisone took away some of my joint pains and so forth.
Oh, that's good to know because I got those. Okay, that's good to know. All right, well, that's all I have, and thank you for listening.
Peter, one thing just to give you a heads up, with the prednisone, it appears you don't need more than 5 milligrams a day.
Okay.
Now, the original approval was with 10 milligrams, and some of the docs still, they still prescribe 2 by 5, 1 5 in the morning, 1 5 in the evening.
Right.
But the evidence seems to say you don't need as much as that you can manage on 5, which is a very low dose, and you can do it either all together or some in the morning, some in the evening. You've got a bunch of guys on this call who are on abiraterone, so that they can attest to that.
What is prednisone anyway? I don't even know what it is.
Prednisone it's a steroid.
It's
So
a
what
steroid.
happens is the drug you're taking, Zytiga, blocks all steroid synthesis, including there are different kinds of steroids. There are gonadal steroids, there are glucocorticoids, and there are mineralocorticoids. And the glucocorticoids and gonadal steroids are blocked by the drug Zytiga. So the consequence of that is you're happy to get rid of the gonadal steroids, but you don't want to get rid of the glucocorticoids, so you have to replace it with prednisone.
I see.
So it's essentially replacing what you're cutting out by taking the drug. And glucocorticoids are essential for many different functions.
Okay.
Peter, you might want to monitor your blood pressure on Zytiga, because about 30% of guys get high blood pressure. That's what happened to me.
Right.
Which doesn't mean you stop it. It just means you take blood pressure meds.
Right.
Yeah,
I had to add a second blood pressure med.
is you can it can raise your glucose. If you're borderline, you might steroids sometimes raise your glucose.
Oh, okay. Yeah. Yeah, I came in at 102 on my glucose, my last one. My A1C has always been steady, good, like 5.1. But I'll watch that. So that just supports the idea of trying to stay as fit as you can when you're on this stuff. I mean, eat right and exercise, right? I mean, it doesn't wipe you out so much that you can't exercise anymore. Is that correct?
Correct.
That's
absolutely.
Correct. Okay.
All right, Peter, thank you. We're going to move on to Dr. John Antonucci.
Hi, guys. So here's my question. And there's a confession in it because I'm doing something bad. Anyway, 7 weeks ago, I went to see my medical oncologist with my legs all swollen up, and he stopped me on my abiraterone. At the same time, the cardiologist stopped me on my amlodipine, a blood pressure pill that can also do that. So then all my swelling went down, and 6 weeks later, I got repeat tests, and after 6 weeks off abiraterone, my testosterone level went from non-detectable to 139. And but fortunately, my PSA remained non-detectable. So I expected him to say, "Oh, it was really working. Let's re-challenge you with it," or let's put you on a androgen blocker. And so I was kind of alarmed because I felt more secure on the double drug therapy. I had only just for the first time reached a non-detectable PSA, and I was really enjoying it. Now I figure, isn't the increased testosterone into 139 going to be followed by an increased PSA and increased activity of the cancer? Now he's perfectly fine to wait, which is not typical of him, but he's like, oh, it's not really changed. He's already waited 6 weeks. So he says, let's wait another 6 weeks. And I'm not the type that can stand to sit around and wait. And not only, here's the confession part, not only did I not, and I argued back and forth a little bit through the nurse, all indirectly, little short answers. I didn't get to talk to him because we didn't have a face-to-face appointment. And I started taking my Abby again. Now, this is a disaster because, of course, I'll run out soon, but I'm anxious without it. And so I wonder what you guys think about this situation I'm in. Should I just say, oh, the doc knows what he's doing? So what if the PSA creeps up a little bit, then he'll just hit it with something? Or should I fight to be on another drug in order to keep my remission status that I'm enjoying?
John, the first question I have for you is, aren't you also taking Lupron?
Yes.
That's amazing that in 6 weeks on Lupron, your testosterone shot up to the 130s.
I was quite surprised. I had always read that adrenal testosterone is only on the order of 10 or 15% of total body testosterone. So, and even when I started all this, my testosterone level was in the 100s, So I was kind of amazed to see it jump quickly and all the way up to nearly where it was before I even got started on Lupron.
Well, I think the simple answer to your question, though, is this is your life. You don't feel comfortable, going off Zytiga. You just tell them, hey, I want to be back on Zytiga. It's that simple.
Is it worth fighting for, you guys think, or is it perfectly? Well, I mean, if you were told to wait another 6 weeks and then another 6 weeks, would you say, oh yeah, sure, that's okay?
Well, Lynn just told you have to be comfortable, John. If you're not comfortable going off it, then for Christ's sakes, tell your doctor.
Yeah. I did write it first, I said, I've got to see, I said, I can't believe I'm asking for a drug that I hate, but I actually am,
So John, you can look, are you having any more peripheral edema? What about the edema?
It's all gone.
So, so the other choice is to take Abby and see if the edema comes back.
That's my rechallenge theory, and that's what I thought might be a thing to do. Rechallenge the patient with abiraterone.
And then if your blood pressure goes up, find another drug other than the.
It's true. My blood pressure just went wild on abiraterone. I had to end up on 3 or 4 blood pressure pills to control it.
I mean, but there are other pills. There are other blood pressure meds, as you well know.
So, John, I got a couple of questions here for you. First of all, we just saw with Gary an error in the testosterone reading. And I find that testosterone reading very, very strange. If you're, what sort of, when did you get your last LHRH shot?
I'd say it was about 7 weeks ago.
And what type of shot was that?
Eligard.
Was it
90-day depot?
6 months.
6 months. Okay. I don't like those 6-month shots. They always make me a bit nervous. But anyway, I mean, but you should have plenty of LHRH in you, right? So yeah. I think the first thing I do is I'd get my testosterone tested again to see. Yeah. And I'd probably do that. Well, you already started the Abbey, but do it before you take too much more. Secondly, and you know this better than most. I assume you're taking the prednisone again.
Yeah,
Okay. Low dose, 5 milligrams?
yeah. I mean,
Yeah.
I know that was a stupid thing to do and I shouldn't have done it. I know that.
Yeah, no, we're not criticizing you for that. We're just making sure that if you're taking the abiraterone, you're
At least am I
also
taking the prednisone? Yes.
That's all we're doing. That's all we're doing. The third thing is that occurs to me is maybe you should try switching to an androgen blocker.
He mentioned that the first time my legs went up. He said, "Oh, you know, we'll take you off the abiraterone and then get some measurements and then put you on enzalutamide or something like that." He thought that at first, but he seems to have changed his mind about it.
Well, you know, I also think you've got to insist on talking to him, and you know, you've got to pull the professional courtesy card too. Don't be shy to put seriously.
Yeah.
You know, I mean, if you know, if you're an MD, they'll talk to you. I mean, you know, we don't have any of our other guys on the call. We don't have Carlos on the call. We don't have Mark on the call. But you can pull your MD card, and you got to talk to him. It's no good going through these nurses. Things get lost in the translation.
Yeah, you write these detailed questions and get these 3-word answers.
That's right.
Because they've gone from the nurse to the doctor and then back down.
That's right.
You know.
That's right. So, you know, I think you've got to say, I need to talk to Dr. Petrolak. There are a few options here. I'm really concerned. Plus, I got a lot of anxiety and I want to talk to him about it. Okay? And you know, maybe you can recommend a good shrink. Sorry. But seriously, I mean, I do think that if you start to see edema again, think about switching, or you know, maybe how long have you been down around that 0.008 level?
Just only just happened within the last couple of months.
So I mean, I'm wondering if it's time that you could be eligible for a holiday.
Oh, I'm still a newbie, I think. I haven't even been a year on these drugs yet.
Oh, okay. No, you've got to try and June 20th. Yeah. So yeah, you got to try and sit it out for another 6 months. Yeah. At least another 6 months.
Let us move forward. How about Jerry Pelfrey?
Okay, Len, if there's no one else, I just have started, it's a trial, but it's not a drug trial. It's actually a trial to see if they can help with our hot flashes. And it was specifically for prostate cancer for men. And the name of the company is Embr Wave, and it's EMBR. And you can look them up, Google them. They've got a full site. But what they have requested is that they sent me this, it looks like a watch, and it just goes on your wrist like a watch. The electronic part of it goes on the inside of your
Muslin
wrist.
is wearing it. You don't need to describe it, Jerry.
Okay. Anyway, I've had it for a week, and I've got to say that it does somewhat help. Doesn't eliminate a hot flash, but it does help in the amount of intensity and the time. I've noticed that.
this last week, and this is my second week now. I don't know how many people are in the study, but I find it very interesting. So you can go out and Google it.
Jerry, is there a number, a clinical trials gov number for this study?
No, it's not a clinical trial. It's actually the Embr company put this out. I forget the doctor's name that called me, but it was all internal Embr.
I think I blogged about this, but I don't. Did you let that go out, Rick, or did you stifle it?
No, we didn't send it out, and Alicia Morgans has been is working with Embr.
Alicia Morgan?
Yeah, Alicia Morgans is working with Embr. Alicia Morgans took this to us too and asked us too to push it out. And I know that I've been going back and forth on behalf of Russ Hoover. Russ, have you heard anything more? Have they approved you? Are you going to get the gizmo?
I'm still waiting for the confirmation, but they say I'm good to go.
Okay.
Yeah, there's a lot of paperwork, a lot of questions that you have to fill out and then send back to them. And then I got a letter of confirmation, and within a week, they sent the Embr watch.
Is this men and women or just men?
I would assume men and women.
Yeah, I
think this particular study. So I'm on it also,
okay.
And it's I got an email from Alicia Morgans. I don't know how she got a hold of me, but so I signed up for it, and it's been amazing. And the best part about it for me is I don't get up at night with the hot sweats, and it's pretty amazing. I spoke to Dr. Peak 3 days ago. They want 50 people in the study, and they've got about half. So if you have,
how can I get in?
I'll put it in the chat window here in a minute.
What is it? Just a couple of acupressure points?
No, it's actually neurological. I don't want to take a lot of time on it, but it's a thermoelectric heat pump that creates the cool or the warm. They communicate with the rest of the body through the autonomic nervous system.
Okay, clever.
Yeah, Jay put a link in the chat.
We're talking. I'm sorry, what, Len?
Is it called Embr Wave by any chance?
Yes.
Yeah.
Yeah, well, you can buy it now for $249.
Right.
I saw their link.
Right, but if you can get it for free with a trial.
By all means, yes.
Yeah. So David, is that what you wanted to talk about, or you have something else for us?
That's exactly what I was going to talk about. That's what I was going to talk about, Len. I'm good now.
Okay. All right. Let's see. Julian Morales, are you still with us? Yes, you are.
I'm still here. Just wanted to report that I had my Breckie boots HDR last Wednesday, and now ready to get into the radiation, but they're going to put a spacer in me sometime next week before they start that.
Okay, very good. Keep us posted.
Yeah.
Any questions for the guys?
Anyone ever had a spacer?
Yes, I did. I had it put in when at the same time they put in the gold fiducial markers. And so they gave me some kind of light anesthesia, probably propofol, and so I felt like I blinked. I woke up and it was all over. You feel a little pressure for a while, maybe a week or so, in that region. Right. But after that, nothing. Yeah, it's Not a big deal.
This came up yesterday in our low and intermediate meeting, and there were a couple of guys that, one had a very hard time with it because they didn't give him the anesthesia far enough in advance.
Oh.
And he had a hell of a time with it. So, make sure they give you something and ask them to give it to you ahead of time and not do it with the insert.
Okay. Any particular drug?
I think it's lidocaine or something like that.
Yeah. Yeah, he said it was going to be a local anesthesia.
Right.
How was your experience getting the HDR, Julian?
Well, funny you asked that, but everything went rather well. They numbed me from the spine, from the midsection down, and I didn't feel anything when they put the needles in. But what somebody forgot to do, because I was having a horrendous back pain, is to turn the catheter back on so I could drain. And finally, the doctor came in and I could hear him say, oops, and he was a little ticked off. But as soon as I opened it up, the pain went away, and I dropped about 350 cc's of urine.
Oh, wow.
That was probably the only hiccup in all of it.
Okay.
So I told him, hey, guys, can't do this again.
That was your second treatment or first?
First one.
So you got one more to go?
No, I go into radiation next.
So you're only having one HDR. Interesting.
Right. They had 13 needles.
Yeah, I mean, some people do one, some of them do one, some of them do two. I was just trying to research that this morning for somebody. But you can do it. You can definitely do it with one. It's really the call of the doc.
Right.
Oh.
But other than that, they did have a software snafu on number 10, but they figured it out and they went through it like clockwork. And no real after effects.
Okay. Well, I'm glad you're well on the way, Julian, and I think you'll find the IMRT part is going to be a breeze.
Yeah, well, I'm hoping. I mean, I don't have, excuse the term, I don't have much of an ass, so the space is going to be something I'll be looking forward for.
Okay.
All righty.
Thank you.
Let's go to Gary Peters.
Hold on a second, then. I want to come back to David Muslin because you haven't given us a report. Last time we talked to you, you had this rash right after your Lupron shot, and we were all wondering what the hell's going on. Did the rash go away, or what's happened with that?
The rash, actually, the rash had gone away before I brought it up, Rick. And I haven't gotten a Lupron shot since then, and I'm going to go see your friend there in a couple of weeks.
And
So,
what about are you less irritable?
I'm a lot less irritable. Yeah, I'm good now. The shot's been over, and I'm okay. And my hope is, when I go to see her, I'll have been on Lupron for 18 months, and I've been on Abby for, I forgot how long. It's probably, I was on enzalutamide, then Abby, so the whole thing's been about a year and a half. I'm hoping I can take a holiday on the Lupron and maybe just stick with the Abby for a while, kind of like what Len's doing, and see what my PSA does.
Yeah.
Or Ken Anderson. Ken's only on abiraterone right now without the Lupron.
Right. So it'll we'll see what she says.
Okay.
And I'll give her.
I'm not saying a word. You come back and tell us. When are you due to see her?
Right after 4th of July. I think the 10th or 17th. I have to look it up. I forgot.
Okay.
Thanks for asking, Rick.
Okay. Pleasure.
I'll give her your regards.
Thank you.
All right, Gary, you're up.
I'm in week 6 of 8 weeks of radiation, and I've been trying to get a clear answer on, in terms of my, where on my body or how wide in my pelvis they have radiated. And I use the term as we have and as Rick does, asking about whether I'm getting pelvic girdle radiation. And they keep saying they don't know what pelvic girdle means. And so I'm wondering if there's another way I can describe what I'm trying to ask.
Well, you could say whole pelvic radiation or whole pelvic region radiation, but for them to say they don't know what you mean by pelvic girdle, that's bizarre.
That's what I thought.
Gary, who are you asking?
I'm asking my radiation oncologist at Sibley.
Really? And he says he doesn't know what it means?
Yeah. And I know that, you know, they've been doing 5 weeks with a wider treatment, and then the last 3 weeks focusing on the prostate bed. But when I've asked to sort of have him sketch on my body where that wider treatment is, I'm having a problem. And when I say pelvic girdle, they say they're not familiar with that.
Do you know, Gary, how many gray they're talking about as far as radiation?
My total at the end will be 7,020.
That's, I think
No.
that's rads and not grays.
That's not grays.
That's
Well,
70.
it could be centigrays, which is 100th of that. So you're probably getting about 70.
70 gray.
70, yeah.
Well, that would lead me to think that you're getting both pelvic and prostate radiation, but you know, you're a radiation oncologist, should no doubt to be able to tell you that.
Right, I know I was getting both. I was just trying to find out, you know, how does pelvic girdle translate to how wide it is on my body?
Is pelvic girdle the same as pelvic floor? Or are they two different terms?
Different.
So Gary, just say whole pelvic region. If he doesn't know that, I'd be tempted to walk away, but you're in the middle of it, so I guess you can't do that.
Right. Okay.
I'm trying to find an article that Alan Adele wrote. Yes, here we go. So here's an article that I'll put it in the chat window. New guidelines for salvage radiation dimensions. And so you can, he calls it pelvic lymph node coverage. And this, I think this ties in. I'm not 100% sure. But you know what you want to be asking him is it covering all of your pelvic lymph nodes?
Exactly.
So you've got to say that, but I honestly don't understand how come he doesn't know, he doesn't understand the term. That doesn't make a whole heck of a lot of sense to me. But so I'm sorry we can't be more helpful to you.
Well, thank you for the site. I'll take that article in.
I just put the link to the article in the chat window, but he's got other articles on that site about the radiation field. I just cannot. I'm just not seeing them right away. But he does. But
And are these guidelines now the standard of care for spread to the lymph nodes?
okay, here you go. So here he's talking about what we were talking about before with George. Whole pelvic cell. I'm sorry, it wasn't exact. I'm sorry, I shouldn't have said that. He's talking about whole pelvic salvage radiation plus short-term ADT. So whole pelvic salvage radiation seems to be a term of the art. I mean, I always thought pelvic girdle was a term of the art too, but what do I know? But I'm putting another link in here for you. I just put 2 links in there, and between those 2 links, you should be able to make some headway with him.
Great, thank you.
And if not,
I'm going to butt in. I'm going to butt in. I just put in pelvic girdle in Google, and it pulled up the pelvic girdle and gave a drawing of the bony structure and gave a drawing and an explanation of what the pelvic girdle was.
Okay,
Well,
thanks, Frank.
I just Googled whole pelvic radiation, and it came up with 6,670,000 hits. So he had better know what that means.
I think he'll know what that is.
Yeah.
I had something I wanted to add. That is, sometimes you ask a doctor a question like that and they're trying to blow you off and they don't want to get, deal with your question. And I think the best antidote to that is something that we were talking about a couple of weeks ago, and that is to send an email ahead of your visit and asking the questions in writing to them. And I think, and I did that a couple of weeks ago, and that made dramatic difference on how seriously they took my questions, because now it's all documented and there's an audit trail that I asked the question and everything else. And I think that really spooks them, but I really think that was beneficial for me, and I learned that from I think Rick brought it up a couple weeks ago, didn't you, Rick?
Yeah. I mean, once you send something to them in writing, or you walk in with a question in writing that you hand to them, they got to take it seriously. Is that right, Dr. John?
That is right. They should take all your questions seriously, but yes, write it down.
All right.
Thank you.
I think before we get to Nelson Pacheco, which we may have to wait till next week, let's see. Let's call on Kang.
Hi, Lynn. I must have heard it wrong. You might have mentioned Ken, but in my ear, I was hearing Kang. So I don't want to take Ken's time.
Oh, no, that's for you.
Oh, all right. Thanks, Ken, and I mistake your time. Upon my persistent advocacy of aggressive treating of my states, and my doctor hooked me up with a radiologist from Mount Sinai also. His name is Richard G. Stock. I don't know if anyone in this forum has had experience with him, or my meeting with him, first meeting with him will be next Monday. Yeah, I mean, it's, I was told there's probably going to be 45 minutes of consultation. That's my question, I guess.
I had a consult with Stock also after I had my PSMA PET scan, and there were, depending on how you count them, 3 to 5 bone mets. And So the consult was, should we hit this with spot radiation or not? And he was a little too eager, in my opinion, in jumping. Oh yeah, sure, I can hit all those spots. And I said, would you be using SBRT? And he said, no, IMRT. And that kind of turned me off. So I went over to Sloan Kettering and consulted with, oh boy, you know who's that guy? Zalewski, thank you. And he said, he recommended against that. First of all, because I had already had 86 gray of radiation. So Zalewski said, no, I think you're better off going on hormone therapy. We'll knock out some of those lesions with hormone therapy, and then if there's maybe one or two left, we can hit it with radiation. So what happened was they all disappeared. I was undetectable and still am for the PSA. So I'm kind of glad I didn't take Stock's advice. Well, that's one man's opinion, just, you know, anecdotal, but.
Yeah, I really, I guess I know nothing about this, but the idea of cytoreduction, taking care of the primary tumor, whether it's surgery or a radiotherapy, to you know, the mothership, the concept of it. My oncologist saw in his mind the way it is, the standard of care with the way it is going. It seems if I don't bring this up, he will be happy with the way it is going now, because the PSA is under right under 0.01, and you know, after I bring up this idea of taking care of the primary tumor, I guess, yeah, well, there's a lot of side effect, whichever way you go, whether it's the surgery or radiotherapy. But if that's where you want to go, and here it is, he gave me the, you know, the Richard G. Stock as a point, so I made a point with him. Other than that, sometimes I don't know with, you know, with the reward and what's that called, the ratio of whether you get a disservice from aggressive treatment or you actually get helped from aggressive treatment. It seems like my doctor would prefer me to stay just with a standard of care instead of going out of the way for radiotherapy, which is, you know, which is confusing from what I have read about the aggressive treatments of taking care of the primary tumor.
So Kang, there's a number of guys, as you know, Ken and Herb and others, who have gone in and had the primary treated. A lot of times when they're treating the primary later, they don't radiate the pelvic girdle. They only they concentrate just on the prostate and the prostate bed. It's never been clear to me why they wouldn't radiate the whole prostate girdle, and probably if it was me, I'd ask them to. But I think that there seems to be more and more. I don't want to say evidence because I haven't seen it, and then I'll be in trouble with Herb. But there seems to be many more doctors that are recommending that you do treat that primary. If you're going to get it treated, I would suggest you do it with SBRT rather than IMRT, because you can do it with a lot fewer sessions if they're only treating the prostate and the prostate bed. To get SBRT for the pelvic girdle is a little tricky because it's still fairly new technology and not everybody does that. But I see Herb switched on his microphone, so that means he's ready to tell us something. Go ahead, Herb. And you've just done this.
Well,
You've just done this.
Well, I've just done it, but more than that, at ASCO, there was an hour discussion of the role of prostate radiation in metastatic disease. And a recent paper came out, which is analysis of the STAMPEDE trial and an extension of STAMPEDE, and it's really clearly beneficial, especially for low numbers of, the benefit is really significant for low numbers of metastases and gets less as the number of metastases gets larger. But, even then there's overlap so that there's a chance of a benefit. So I would argue that, and then one of the physicians in this session is arguing that this should be standard of care now.
Okay, this helps. This helps for me to go forward with it. SBRT, IMRT, what's the difference between the two?
Well, the SBRT, you can do it in much fewer sessions. You can do it in 4 sessions versus maybe 20 sessions. Did you have SBRT, Herb, or did you have?
Yes, I had SBRT.
And how many sessions did they do it in?
5 sessions.
5. So I think that you really have to push for that as well, Kang.
Okay.
Because a lot of the doctors will say to you, "Oh, we can't do that," or "It isn't a good idea," because they don't do it. But it's available and it can be done. And as you heard, that's how Herb got it. I know Ken got many more. But if I was going in today, I'd be asking for SBRT and not IMRT if they're only treating the prostate. But if they want to treat more than that, they may have to treat the pelvic girdle with IMRT. Well, excuse me, the whole pelvis. Is that what I'm supposed to say now?
Apparently.
Is brachy an option or it is not? If it's
that's a great question. I don't know anybody that's had brachy for treating the primary, but I would think that HDR could be the rods could be an option. I don't. That's a great question. Anybody know or ever heard of that being done? But there's not a huge difference now between using SBRT and using brachy, according to Mac Roach.
Okay, thanks. I was just thinking that brachy seems it's more concentrated in high dose in that particular mothership board. I mean, on board with the mothership. Probably.
Yeah. Well, so is the SBRT, Kang. That's the point of the SBRT. It's a much more concentrated dose of radiation.
Okay. Yeah, I got it. Okay. Thank you. Yeah, I'm ready.
Anybody else?
I had some confusion with what is SBRT and what isn't. I had trouble getting a straight answer from the radiation oncologist as well. And yeah, they were hesitant on telling me I was getting SBRT, but when I finally pushed the issue enough, they said it is SBRT. But they said, it just depends on how many fractions of radiation that you're getting, on whether or not it's specifically classified as SBRT, and what's considered in Canada to be SBRT with the number of fractions that they consider SBRT is different in the US. Yeah. And it ends up being an insurance issue in terms of what's actually covered and how they're compensated and things like that. So it was kind of a slippery fish to try to get an answer on exactly, is this our SBRT I'm receiving or not? And then finally, one of the radiation oncologists sat down and explained to me it is SBRT. But they were hesitant on classifying that because I guess the compensation could be different from an insurance company standpoint.
Yeah. I think there are many different types of equipment that deliver this stereotactic body radiation now, and but I think that it's largely defined by the size of the fraction. So it has to be a much larger fraction than what you get in an IMRT dose. Herb, do you know the answer to that?
Yeah, I mean, it's not simply fractions. It's also that it's stereotaxically guided and much more localized so that the field of radiation can be much more discrete rather than with image modulated IMRT.
Right.
So you
Guys,
get higher dose and fewer fractions.
We have another meeting starting in this room at 5, so we can keep going until some people come in. And Jake, will you just cut the recording when, and then, you know, as the caregivers come into the room, you guys can gently drop off, or if your partner or your wife or your partner happens to be standing outside the door, pull them in, sit them down in your seat, and you move out, and we'll take care of them in the caregivers session. So
I think I need to move on here at 8 o'clock, but next time I'll give you an update of where I am, if that's okay.
yeah, please do. Sorry, Nelson, we're having to cut this session off because we've got this weird June schedule, but we won't have the June schedule after today anymore. Well,
No
until
problem.
we have
Actually,
another
I
one
learned
when Mondays and Tuesdays.
Yeah, I learned a great deal because a lot of what was talked about applies to some of my questions, so that helps me.
Okay, we'll come back next week. Don't wait 2 years or whatever it was.
Okay, okay.
Okay.
Right.
Okay, should I stop the recording now?
Okay. Okay.